dear Professor Shahzeb Satti. He is a professor of medicine at Army Medical College and a consultant pulmonologist at PEMH Rawalpindi. He is also a member of High Altitude Medical Research Center. And the topic is vaccinations in pulmonary diseases. So please.
Bismillah ar-Rahman ar-Rahim, sir. Thank you very much, Mahmood. I'll take forward whatever Sir Javed has said. So basically, the aim of this presentation is to understand the importance of respiratory vaccinations and to know some common respiratory vaccines. So as you can see from this chart, there is an increase in the population of the elderly over time. And in 1960, the Pakistani population above 65 was 930 Ks, which has increased to 10.2 million by 2022. Just to give you a correlation, as the life expectancy has increased, so has the incidence of invasive pneumococcal disease over time. So why the elderly are more prone to infection? This is a phenomenon which is called as immunosenescence, whereby there is a decline in function of both the innate and adaptive immune system that results in decline in the T cell and B cell population, and hence an increased propensity for infection, and as well there is a reduced response to vaccine. The chronic respiratory disorders, according to this Global Burden of Disease survey, is the third leading cause of death worldwide, which was responsible for more than 4 million deaths. These are some of the major vaccines, and I'll be more focusing on influenza and the pneumococcal vaccine. Influenza, we all know, mainly caused by the influenza A and B viruses, and there is in every winter there is a seasonal epidemic. These viruses are basically classified on the basis of neuraminidase and hemagglutinin, which is present on the surface. There are 18 different types of hemagglutinin and the 11 neuraminidase. We know H1N1, the swine flu, and H3N2, which commonly circulate in humans. And these influenza A viruses are primarily responsible for the global epidemics. The phenomena of antigenic drift and antigenic shift are basically, there's a change in the viral protein antigenicity as well as emergence of a novel influenza A virus infection, respectively. So there was a substantial annual effect of influenza on the global health, as well as health loss due to the seasonal influenza low respiratory tract infection should not be overlooked, and vaccine use should be considered. This was found to be, influenza virus was found to be the third leading microbiological agent responsible for community-acquired pneumonia in a North Indian study. Middle and older age adults and those with a history of COPD were more prone to infection as well as increased odds of death and ICU admission. Similarly, older adults and those with diabetes are more prone to develop severe influenza virus infection. Just to summarize the impact of vaccination upon different COPD patients first, as you can see from these summaries, that there is, after the vaccination, there is reduced exacerbations and low risk of respiratory failure in chronic COPD patients. Similarly, the vaccination was associated with reduction in all-cause and cause-specific mortality, as well as 38% fall in the number of in the cases which were diagnosed with influenza. In asthmatic patients, similarly, there was a meaningful protection. In fact, 55 to 78% reduction in the influenza cases after the vaccination was provided to them. Similarly, there was a good reduced risk of hospitalization in these and reduced risk of exacerbations as well. So all in all, the NIC at Islamabad, after this study, they emphasized the need for continuous and comprehensive influenza surveillance to predict the seasonal trends and well as for the vaccine development. There are basically three basic types of these vaccines: the inactivated vaccine or the egg-based vaccine that we commonly use intramuscularly. Then there is a live attenuated vaccine which is given nasally, and then there is a recombinant vaccine. The 2023 tetravalent vaccine contained these 4 viruses: the H1N1, H3N2, the B Victoria, and B Yamagata. But it is important to remember that these vaccine antigens are selected based on global surveillance of influenza viruses circulating at the end of previous season. So there can be mismatch between vaccine strains and circulating strains, and that can lead to diminished efficacy. Henceforth, in the 2019 guidelines, there was a recommendation that all with chronic respiratory disorders, bronchiectasis, interstitial lung disease, asthma should receive annual vaccination. But to carry it further, the CDC has recommended that all individuals above 6 months of age should receive vaccination universally and globally, which of course is not possible. Therefore, we should select the target population with the highest risk of influenza-related complications, which include adults above 65 years of age, pregnant females, those with chronic medical conditions like chronic respiratory disorders, and then the healthcare professionals. But in this study that was conducted in Pakistan, there was lack of awareness amongst the healthcare professionals about the nosocomial spread of infection, this influenza, and therefore reduced vaccination rate. And similarly, despite a positive knowledge, attitude, and practice score and published guidelines, a very low percentage of healthcare professionals were vaccinated. May I ask, all of us are healthcare professionals, how many of us received vaccination last year? So the study is also going in favor. I will not talk about the COVID-19 vaccine. We know it, we have been through it. So now it is recommended above 6 months of age and then booster thereafter. Now, the Streptococcus pneumoniae, we all know, is a gram-positive diplococci, and the main virulent factor is the polysaccharide capsule that is surrounding it. And it defines the serotype, and it is also the virulent factor. More than 90 different serotypes they are circulating, and out of that, 27 serotypes are responsible for the 90% of invasive of the pneumococcal diseases. It was found to be the leading cause of lower respiratory tract infection, mortality, and morbidity globally. More than half of all global bacterial deaths in 2019 were caused by 5 bacterial pathogens: Staph aureus, E. coli, Streptococcus pneumoniae, Klebsiella, and Pseudomonas aeruginosa. So analysis found that 1/5 of the adult population suffering from the community-acquired pneumonia had the diagnosis of Streptococcus pneumoniae. Similarly, the vaccination of pneumococcal infection in patients with COPD and bronchiectasis can reduce the number of exacerbations, incidence of pneumonia, and the number of hospitalization. In fact, Streptococcus pneumoniae is responsible for 10 to 15% cases of COPD exacerbations. There are 2 main types of vaccines which are available, and these vaccines, the active component of both of these vaccines are the capsular polysaccharides from pneumococcal serotypes. The polysaccharide vaccine, which is composed of partially purified pneumococcal capsular polysaccharide, and it has 23 serotypes. Whereas the conjugated vaccine, which consists of pneumococcal capsular polysaccharide that is covalently linked or conjugated to a protein. Over a period of time, there has been development from PCV7 to 10 to 13, and now in the last 2 years, 15 and 20. The main difference in their mechanism is that the polysaccharide vaccine, it mainly causes the release of immunoglobulins from the B cells. Whereas the conjugated vaccine, it has a durable protection because of the T cell mediated mechanism and then the resulting memory B cell formation. And there is also herd immunity and the mucosal immunity with the conjugated vaccine. As you can see from this, that after the introduction of this vaccine, there was a downward trend in the number of cases of invasive pneumococcal disease. So there is a slight edge to the conjugated vaccine over pneumococcal vaccine because of its enhanced immunogenicity, the mucosal immunity, the herd immunity. But at the same time, the use is associated with the replacement strains. That is, those strains against which the conjugated vaccine is affected, they are suppressed, and the other strains, they take over. So just to give you an example, this basically shows the serotypes against which the PSV23 is effective, and these are the serotypes against which PCV13 is effective. So it is primarily given by the intramuscular injection. So these are certain challenges associated with the vaccine, the current vaccine strategies, including the emergence of non-vaccine serotypes, inadequate protection against those serotypes which are not included in this vaccine, and very importantly, a complex vaccination schedule which was there. In order to simplify the issue, the ACIP of CDC, that is the Advisory Committee on Immunization Practices, had given the following guidelines. I'll show you in these slides. So for all adults above 65 years of age who have never been vaccinated should receive a single dose of PCV20 or PCV15. For those who have received a PCV15, the vaccination, it should be followed after 1 year by PSV23 in order to complete the vaccination series. Whereas if somebody has received a single dose of PCV20, then a further dosage is not required. Whereas for adults between 19 to 64 years of age, they are basically classified as those having a high-risk condition. Now, these high-risk conditions are as flashed on the slides. Just to give you some examples, this includes the CSF leak, the cochlear implants, and the chronic respiratory disorders, and certain immunocompromising conditions. Now, the vaccination schedule is almost the same. That is a single dose of PCV20 or PCV15 followed after 1 year with PSV23. But in certain immunocompromising condition, you can reduce the duration from 1 year to 8 weeks. For those who have already received a single dose of PSV23, it should be followed by PCV20 or PCV15 after 1 year. And those who have received a single dose of PCV13, the vaccination series should be completed by giving PSV23. And if somebody has received both of these, they do not require any further vaccination. This is the recommendation till now. So if a clinic or a country wants to stockpile single vaccine, the answer is PCV20, which unfortunately is not yet available. So just a few comments about the other vaccines. This is the latest vaccine, the respiratory syncytial virus, which is recommended for adults above 60 years of age, especially in the late summer and early fall, just before the RSV starts to spread or circulate in the community. The CDC recommends diphtheria, tetanus, and acellular pertussis vaccine across all ages. In fact, for the younger, they are DTaP, and for the adults, it is the Tdap and TD. The basic difference between the two vaccines is for the DTaP, the diphtheria and the tetanus toxoid component is less as compared to the Tdap. And finally, we have the hip vaccine, which is recommended for the adults with certain conditions, like 2 weeks prior to splenectomy or any time afterwards, if it is not given prior to that, and those with bone marrow transplant recipients. Thank you very much. I would just like to say that we should emphasize the importance of these vaccinations. A simple measure, and you can see the impact of it. And for all the doctors, and especially for pulmonologists, we should have it printed on our prescription pad so that we should also remember it, and it's a reminder for the patients also. Thank you.
Thank you.